Welcome to Black Health Matters. I'm Daryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
That's at least those are the dietary tips for if you want to live to be 100 years of age. Anyway, who wants to live to be 100 anyway, right?
I do.
No, I don't.
100
You
years
do,
old.
Dr. Calendar. You're on your way.
Well, we're all on our way.
Right.
Yeah.
You're closer.
Yeah, I'm just the closest, except for
Years old with good health.
Dr. Ivy, who's 91. But
Okay.
most of us.
Good morning. My mom is 96.
Oh, wonderful. Good. Okay. Anyway, we're blessed today to have Dr. Constance with us, who's the Associate Professor of Medicine and the Chief of Division of Nephrology, as well as the Medical Director of Dialysis at the Howard University Hospital Center. And she's going to talk to us today about an area that she has become very accomplished in, and that is the area of renal disease. That's an area, of course, that I have a great interest in, and an area that many of our people on this program have a great interest in. And so, without further ado, we're glad to have her again. She was with us before and did such a spectacular job that we asked her to join us again. So, Dr. Murray, the floor is yours.
Yes, good morning, everyone. Thank you so much for inviting me back.
Morning.
And yes, Dr. Callender, I have a couple of slides I want to show.
Sure.
Can you allow me to share
Of course.
my screen? Let me see. Okay. Let's see if I can find, let's see, not here. Let me open this up and see how I can share it.
Well, you got two experts here, so they can help you.
Yeah, I just prepared like 9 slides. I wanted to talk about health literacy and the Department of Health and Human Services. You know, they have this Healthy People Initiative. I think it's been going on since 2010, talking about how to make the nation, the US, healthier. You know, so they are promoting good health habits and trying to prevent preventable diseases and communicable diseases. So the Healthy People 2030 initiative. So I had a slide on that as it pertains to kidney disease. So I'm trying to.
Yeah, you're almost
there. Yeah.
Just double click it.
Okay. So this is actually not the, well, this is a full lecture, but that's not what I intended to share, but I'm going to open this up and just go through the parts that I wanted to go through. Okay. So this is the Healthy People 2030 objectives for as it pertains to chronic kidney disease. So CKD stands for chronic kidney disease. So it's to increase the proportion of people who get follow-up care 3 months after episode of acute kidney injury. So an example of this is somebody has the flu or an infection, goes into the hospital, very sick, admitted to the intensive care unit. They develop worsening kidney function, so not making much urine, their creatinine. So this is a test we use to estimate the GFR and how well the kidneys filter waste. The number is high. You know, it may be severe enough that they need dialysis temporarily, or it may not be that severe. It may be just a 50% decrease in their kidney function. And they get better from the infection resolves, the kidney function improves, right? And they're discharged from the hospital. what this is saying is we need to check up on those people at least 3 months after they leave the hospital, after that episode of AKI, because those people are known to eventually develop chronic progressive loss of their kidney function and develop kidney failure where they need dialysis or transplant. So it's important that everybody, and the overarching goal of Healthy People 2030 is to improve health literacy amongst the population and also amongst healthcare providers, so we all know what to do. So if you don't have,
Excuse
Go
me,
ahead.
doctor, your display is not showing. All we see is the list. You have to double click on that
I'm
slide.
sorry. Yeah,
Then
okay.
it'll open up for us.
Slideshow, okay. Can you see it now?
No,
No.
we only see your list. You're gonna have to click on that show on your screen.
Okay, let's
And then
see.
you might want to come out of this share and then go back to your slideshow and share that.
Okay, so
There you go.
let me go back
All right.
and then go back
Share.
here.
That's
Now,
it.
now we're getting it. All right.
Yep, that's it.
That's it? Okay. Okay.
It doesn't have, it's not on the slides yet, though.
Is it, can you see it now?
Yes. There you
Now
go.
we can, yes.
All right.
Okay, good. Yeah, so I was talking about acute kidney injury. So it's important that everyone knows that, you know, if your loved one, or if you develop an episode of reversible kidney failure, you still need to continue to follow up with your primary care doctor or a nephrologist, you know, just to make sure you don't develop progressive loss of kidney function. And there are ways we can slow down the progression. The other goal is to increase the number of people who get screened, of people with chronic kidney disease, actually, who get recommended tests. So there are tests we do for people who have chronic kidney disease to make sure the kidney disease doesn't progress. As you all know, we can't prevent kidney failure, but we can delay the onset of kidney failure. And the way to delay the onset of kidney failure is to use medications we have available. And, you know, this is a good time to be a kidney doctor because we have so many new medications available that have been shown to slow down progression and delay the onset of kidney failure. So this, you know, the increasing the proportion of people with CKD who get this test, it means also increasing awareness. People should know what tests they should have when they see their doctor. There should be constant communication between the patient and provider, patient's advocate or caregiver. You know, everybody needs to understand what we need to do, and I have slides showing what we need to do, what the recommended tests are. The other goal is to reduce the rate of new end-stage kidney disease. And the incidence continues to increase, especially amongst ethnic minorities, you know, Asians, people who identify as Hispanic Americans, African Americans. So the incidence continues to increase, and also it continues to increase amongst the elderly, people over 60. So the way you know what you should do is if you get screened, if you get tested. So everybody needs to get tested at the annual physical exam with their healthcare provider. The other one is to reduce the proportion of adult dialysis patients with catheters. So when people do develop kidney failure and they choose to do hemodialysis, the best way, the optimal way to do dialysis is to use a fistula or a graft. So, well, the fistula is the best way to start, and the next best option is a graft. Catheters are meant to be temporary because they can cause they can clot off, they can get infected, you know, they can cause serious health complications. So we don't like to use that permanently in people. We like people to start with the optimal fistula at the first time. The next goal is to increase the proportion of patients who get kidney transplant within the first 3 years of dialysis treatment. So kidney transplant is the best treatment if somebody is diagnosed with kidney failure. Unfortunately, not everybody may be a candidate for transplant for various reasons. The most common reason is a decreased life expectancy. So somebody who is not likely to survive the next 2 or 3 years won't be a good candidate for kidney transplant, or somebody with active malignancy, so but this is saying that even if you do start dialysis and you're a good candidate, getting a kidney transplant within the first 3 years is better than being on dialysis for a very long time before getting a transplant. So what we're pushing to is start evaluating people to see if they're suitable to get a transplant even before they need dialysis. Get them on the wait list early enough so that within the first 3 years they maybe get a kidney. Of course, the other goal is to reduce the death rate of people on dialysis, and part of that is making sure they get very good care before they even start dialysis. So very good care for not just their kidneys, for their heart, because heart disease is very common amongst kidney patients, and that is the #1 cause of death: a heart attack, stroke, heart failure, and abnormal heart rhythms. Those are the common cause of death amongst people with kidney disease. And then for those who have diabetes, the goal is to make sure that they get the appropriate testing of the urine for protein frequently. So frequently would be at the minimum every 3 months or longer if they don't have a lot of protein in the urine, because we know that those who have protein in the urine tend to progress faster than those who don't have protein in the urine, and the medications to suppress protein in the urine and delay progression. So this is, again, this was in 2019. The Department of Health and Human Services also specifically for those who have kidney failure, the goal is for 80% of new patients, newly diagnosed kidney failure patients, 80% of them to receive home dialysis or a transplant. And the goal is by 2025 to have 80% of these patients. Home dialysis has been shown to be better in terms of outcomes than in-center dialysis, because dialysis is done more frequently, and we tend to control or remove the waste better. People tend to feel better, eat better, have more energy when they do home dialysis or get a transplant. The other goal is double the number of kidneys available for transplant. And also have 25% fewer Americans developing kidney failure by 2030. So let me go over to how we improve the diagnosis of kidney disease. 2 tests. It's a urine test for to measure the protein, and the blood test to obtain the creatinine and estimate the GFR. So I'm just keeping slides that are more for, I use for my resident doctors. I used to teach them.
What is GFR?
GFR is glomerular filtration rate. So the normal GFR is 90 mLs per minute or more. So what it tells you is how well your kidneys are filtering waste. So an easy way to understand that is if more than 90 is normal. So we usually say you want your waste to be filtered at 100%, at a rate of 100%. Everybody understands that 100% is a good thing. If you have 100% on a test, you're happy, you have an A. So if we measure a blood test called serum creatinine, and we use that to calculate the GFR. So we use a calculator to get that. And if your number is less than 60, that means you have kidney disease. You're filtering at a rate of less than 60%. So that is, I think, a C or something. So nobody wants that. So that this is a tool we use to educate our training doctors, our patients, on how to understand their kidney function. So you have to understand how well your kidneys filter waste. You want it to be 100%, that's normal. And the other thing is you want to make sure you don't have protein in the urine, because protein in the urine is like having an oil leak. You have a car and you have an engine oil leak. If you ignore it, one day you'll try to start your car, it's not going to move. So having protein in the urine is like having an oil leak. If you don't give specific therapy to decrease the protein spilling into the urine, then eventually that can lead to worsening of your kidney function, and then kidney failure. So those are the two important tests to know. Anytime someone goes to see their doctor, so if you have risk factors, if you have diabetes, if you have high blood pressure, you have cardiovascular disease, so heart and blood vessel disease, if you have a family history of chronic kidney disease, if you have the other things that are not listed here, if you're over 60 years old, because we know that as we get older, we lose 1% of our kidney function starting at age 40. So even when you're 70 years old, your kidney function shouldn't be less than 60, even if you've lost, 1 ml per minute. So, it should be about 70. If you're 80 years old, you may be down to 60, 90 years old, down to 50. So it's only the very old that may have a GFR less than 60, and it may be normal for them. So a low GFR at the very old, when you're very old, may not be abnormal. It may be just the aging process. But if you have protein, so the UACR stands for protein in the urine. It's albumin to creatinine ratio. Albumin is a type of protein that shouldn't be found in the urine. There are other types of protein that can be found in the urine, but albumin shouldn't be found in the urine. It's a sign that the filters of the kidneys are damaged. The holes are bigger, and this is spilling into the urine. So those two tests should be done. People with sickle cell disease should also be screened. People with infections like HIV need to be screened, because these are things that are known to cause kidney damage and kidney disease. Hepatitis B, hepatitis C, also COVID-19 can cause kidney damage and kidney disease. Especially in those who already have kidney disease, it can lead to kidney failure. So it's important to continue to practice the safety measures to protect ourselves from getting COVID, even if we've been fully vaccinated, because you may even have mild COVID, and if you have underlying kidney disease, that may make things worse. So, anybody with this and people over 60 should be screened for kidney disease. So these are the two tests, the GFR and the urine protein. And if any of those two are abnormal, you can diagnose kidney disease and confirm it by repeat testing. So you can be retested a month later just to confirm the diagnosis. If everything is normal and there's no diagnosis, continue to be screened at your annual visits with your healthcare provider. If kidney disease is diagnosed, then the single most important thing we need to do is make sure the blood pressure is controlled. The blood pressure the goal is set between the patient and their doctor based on other things going on with the patient, other comorbid conditions. Do they have diabetes? Do they have heart failure? And other things. So the blood pressure is the single most important thing to do, to control. If you have diabetes, blood sugar control is also important. Medications we use, just know that we have many medications. I've listed 3 here. There are other medications we can use that we know can protect the kidneys and also protect the heart. We test for complications of kidney disease and treat the complications. We vaccinate patients, because kidney patients tend to be prone to infections. Their immune system is impaired, and they can get the flu easily, COVID, pneumonia. So they're vaccinated against common communicable diseases and infections. Make sure we review medications, make sure they're not taking, and another important thing is to make sure patients are not taking any medications that could hurt the kidneys, what we call nephrotoxins, that could make the kidney function worse. The most common one people take is ibuprofen, what medication labeled as NSAID. Okay, so ibuprofen, Motrin, Aleve, Advil, meloxicam, all these common over-the-counter painkillers, except for Tylenol. Tylenol, the other name for it is acetaminophen, or baby aspirin. Those ones don't damage the kidney unless you overdose on them. But the ibuprofen and Motrin, they can be harmful to the kidneys even when you take them for just a few days for a headache. We reduce cardiovascular risk by making sure we stop smoking. So a smoker should stop smoking. Not only is it harmful to the heart, it can also cause progression of kidney disease. We make sure the cholesterol is treated to a goal that is good, that the guidelines recommend that will lower the risk of heart disease and stroke. We also make sure that we are exercising, we're physically active, okay? So even doing chores around the house, mowing the lawn, walking, is good, walking in the neighborhood, walking in the mall, wherever. That's important. A healthy diet. So a diet rich in fruits, vegetables, whole grains, fiber, low salt diet, low in animal protein. So minimal red meat, eat more fish, avoid sweetened beverages. So the sodas, the juices, so, just a healthy lifestyle here. And then the interdisciplinary care is, we'll make sure that the patient is working together with not just their primary care doctor. If there's a dietitian available, a social worker, for people who have problems obtaining their medications, so they're different team members who come together to make sure that the care is appropriate and successful for each individual patient. I listed here some risk factors for kidney disease: diabetes, hypertension, history of reversible kidney damage, also called acute kidney injury, frequent use of NSAIDs, so the painkillers like Motrin, ibuprofen. Then if you have a family history of kidney disease, diabetes, or hypertension. So when we get together with our families, we need to share our medical history, especially what we call the first degree relatives, the children, the parents, and the grandparents. We're not talking about cousins or other people. So it's just that parents and their children and the grandparents. That's what we call first degree relatives. People aged 60 or older, and then U.S. ethnic minorities. So those are the risk factors. Let's see. I think this is more for.
Doctor, I had a quick question while you're doing
Yes,
it.
go ahead.
Your kidneys filter the urine or the blood or both?
The kidneys filter the blood and make urine. Okay, so think about the filter in your refrigerator. The water goes through there. So whatever the waste is the urine. So it's the blood that is passing through the filters within the kidneys. So the kidneys are made up of tiny filters, about 1 million in each kidney. So those tiny filters are called nephrons, and the blood passes through those nephrons, and the clean blood returns into the body, and the waste is what you see as urine. So the kidney doesn't filter the urine. Urine is the wastewater.
Thank you so much. That's perfect.
Okay. So this is my last slide I'm going to share, just to show you what we call the heat map. You can Google this. If you Google CKD heat map, it'll pop up. I like to use this to show whenever I encounter a patient and we review the lab tests. I'll say, okay, Mr. Smith, today we did your blood work and your GFR is 93. So this is where you are. So G1, GFR of 93, you're here. That's the green part, right? But I measure the protein in your urine also, but your protein in the urine is severely increased, is more than 300. So that puts you now in the orange part instead of the green part. So everybody understands that green is good. Green is the color of money, color of grass, trees, and all that. So green is good. So this orange part, so instead of being in the green part, because he has protein in the urine, it's put him in this orange part. An orange part means that he's at high risk for developing kidney failure, and not just kidney failure, other complications that go with kidney failure, heart disease, heart and blood vessel disease, increased risk of death, increased risk of developing acute kidney injury on top of the chronic kidney disease. So even though the filter is working well, it's filtering waste well, but it's already damaged. He's spilling lots of protein in the urine. So when I say this, I'm going to say, you see here, because you're here, we have to double down on our efforts. Do you smoke cigarettes? We have to stop. I'll prescribe something for you to stop smoking. You need to start exercising, lose weight. I forgot to talk about obesity in the risk factors also. Being obese also increases your risk for progression. So we have to lose weight. We will have a plan. And most importantly, I want you to check your blood pressure at home. You know, if you can do it every morning, fine. If not, at least 3 times a week. We need to make sure that when you leave the office, your blood pressure is at this goal. We usually say less than 130 for the top number and less than 80 for the bottom number. Guidelines suggest actually much lower numbers. So it all depends on what other problems the person has and how many medications they're taking and if they're suffering from side effects of medications. So another person may have a kidney function of let's say 50. So, and then no protein at all in the urine. And you can see the color code here is yellow. It's better than the orange. So yellow is increased risk. I don't know, it's not really increased, but it's not very high risk. Okay, so even though the function is decreased, compared to the person with a normal function and lots of protein, they're better off. So this is a tool, we can. So I encourage everyone, if you can, get this off the internet, print it out, or even, have it on your phone. You can take a picture, save it to your phone. Whenever you see your doctor and you do blood work, you can say, where am I on this chart? That way you understand. If it's green, you're reassured, you continue. It means whatever you're doing is working, keep doing, make sure everything is a goal. If it's yellow or red, the question, or your red, actually red is, the highest risk. The refer means you need to refer to a kidney doctor. So all these ones that have high protein, you have to refer to a kidney doctor. And then kidney function less than 30%, refer to a kidney doctor. So then you ask the doctor, what can I do to make things better, to go this way? You want to go left. This is the only time in life you want to go left and not go right. So if you want to ask your doctor, what can I do to go, make the protein better? What medications can I take and all that? You heard that there are medications out there that can decrease protein in the urine, and these, if you are the advocate for a family member and you go to the appointments with them, have this chart available, even if they've not been diagnosed with kidney disease. Anytime you're reviewing blood work, it's likely that kidney tests are part of the blood work. You can ask the question, where does my wife, where does my mom, my husband fall on this chart? And then what can we do? Is it time to see a kidney doctor? And things like that. So you have a treatment plan based on this. So I'm going to stop here so we can have a dialogue, a discussion about this. I hope this is helpful, and I'll take any questions.
Thank you
Yes,
very much
Doctor,
for the excellent presentation and the opportunity for us to have a dialogue. I guess Mr. Tatum has had his hand up for quite a while. You want to start off the question, Mr.
Sure.
Tatum?
Yeah, thank you. Very good presentation. I wanted to know how does a person feel if they're having kidney failure? I mean, aside from being tested by your doctor, I mean, you're walking around and you feel fine. What are the signs that you may have kidney problems?
That is an excellent question. There are no warning signs. That is why you get tested. Most things that don't have warning signs, we do screening, like colon cancer screening, breast cancer screening, prostate cancer screening, because earlier on in the disease process, if you want to catch something early where whatever you do can make an impact, you have to screen. When you start having symptoms or signs, it's already too late. That is when you may be considering dialysis or transplant. And those signs and symptoms are swelling. Okay, so swelling of the feet or swelling of the legs, tiredness, so lack of energy, things you normally do, you can't do, you don't have the energy to do it. You may have loss of appetite, food tastes different. So things you like to eat, people tend to say they're meat, chicken, beef, turkey tastes different. They have an aversion to eating meat. They may have difficulty with their breathing. They may have indigestion and bitter taste in the mouth, itching, bruising, okay? Because the kidneys perform a lot of things in the body other than just removing waste. So then we have, so itching, just mental fogginess, they can't concentrate very well, okay? So these are symptoms and signs you see in late stage kidney disease, what we call stage 5, where it's time to start talking about transplant or dialysis. So you don't want to get there. And one thing you should know is, notice I didn't talk about the urine. People continue to make urine, but they're not removing the waste adequately. So I have patients who have been on dialysis for 5 years who still make urine. It doesn't mean that your kidney is working if you make urine. That's why we need to do that test to screen for it.
All right, thank you.
Dr. Atto is next.
Yes, very good. Thank you very much. This is a very good presentation. My question is just a little bit general. On the average, how long can a kidney patient, a person who has either kidney failure or kidney disease, on the average, how long do we expect him to live or her? And I ask this in light of this Ekweremadu. I don't know whether you are familiar with this senator, Nigerian senator, whose child has been in London for, is having a kidney problem, and she's over 25 now, and she's living sort of a healthy life. And how long can she live, without a kidney transplant? Because they are trying to get a kidney for her.
Yeah, so she must be on dialysis. I'm familiar with the story, but she must be on dialysis. So kidney transplant is the best treatment for kidney failure because you're getting a new kidney. You have to take medications for life, though, so you don't reject that kidney. So while you're waiting to get a kidney, you do dialysis, and there are 2 types of dialysis. I didn't go into that because I wanted us to focus on preventing kidney failure today. So there are 2 types of dialysis. There's hemodialysis and there's peritoneal dialysis. Hemodialysis can be done at home and can be done in center. So in center means going to a clinic, a facility, a hospital to do it. And at home, you are trained by the nurse to do it yourself at home. Peritoneal dialysis is only done at home. So people who are on the kidney transplant wait list are on dialysis. If they have kidney failure, they're on dialysis. So with dialysis, life expectancy has improved a lot because of the different ways we're doing it, especially like doing the home dialysis now, doing it more frequently. So I would say, I'm trying to remember the data I saw recently. At 10 years, about with transplant, life survival at about 10 years is about 90 something, more than 90%. With hemodialysis is about 50%. So that's the difference. And peritoneal dialysis is that way. Definitely, if you choose not to do any of those, no dialysis, no transplant, most people die within a few months.
Oh, okay.
Yes.
Thank you.
Yeah. So if you have kidney failure and choose not to do anything, within a few months, you could, the person would die, or even a few weeks, they would die. Yes.
Thank you.
You're welcome.
Dr. John Buchanan is next.
Yes, doctor. You almost answered my next question, which was about home dialysis. Maybe talk just a little bit more about that. How does that work? You have to get
Okay.
trained. Do they have equipment that you have to send home? Can anybody get that, or is it real expensive?
Yes. So let's talk about home hemodialysis. So home hemodialysis, you need a fistula, so a shunt in your arm so that you can stick yourself. You can't do that with a catheter. You can't do home hemo. We don't encourage doing it with a catheter. So the needle, we use 2 needles to stick the shunt in the arm and then connect to the machine. So the training is done. The machine is actually a small machine that is like the size of these mini refrigerators, that can fit in your bedroom. But there's training. It entails some training that may take up to, anywhere from 2 weeks to 4 weeks for you to learn how to cannulate the shunt and also learn how to set up the machine and troubleshoot the machine. There's always backup phone number you can call if you have problems any time of the night. Anybody can be trained to do it. Most insurances cover it. And as you see, it's one of the goals of the Healthy People 2030 that people use more home therapies. It's cheaper for insurance companies because they don't have to, you don't have to come to the hospital and they'll pay the facility fee and all that. So you do it yourself at home. The peritoneal dialysis is less frightening because you don't deal with blood. A catheter is put in the belly and the solution is run through the catheter into the belly and it sits there for a while and then you drain it out. A machine can also do that. The machine is small enough to sit on the nightstand table. So insurance is paid for both, but you start off in a dialysis clinic where you are trained. If you can bring another person to be trained alongside you so that the days you're feeling too tired, the person can help you with the dialysis. Yes, so I don't know if I answered all the questions you asked.
That's great. Thank you very much.
Okay.
Thank you.
Next would be Janice Stevenson, and then
Yes, thank you. I have a question. I have a friend who needs a kidney transplant, and he's been on dialysis definitely over 2 years. I don't know exactly how long. And recently I noticed he coughs a lot. There is a heart condition involved, and he coughs a lot, but his stomach is swollen. Oftentimes when I talk to him about it, I don't think he quite understands where he is in the process or what the process is. But is it normal to have that coughing and the swelling in the stomach?
So he said he's on dialysis. Does he do dialysis in the center 3 times a week?
3 times a week.
Yeah, so people who do dialysis 3 times a week is not uncommon to see, swelling of the belly, swelling of the legs, because remember, you do dialysis 3 days a week. The other 4 days, nothing is coming out, right? The fluid, you're retaining that fluid. Yes, fluid in the lungs can cause cough. Okay, but the cough could be any other thing. There are many things that can cause cough. Allergies can cause cough. So it'll be important for him to make sure to discuss with his kidney doctor. So the nephrologists come to the center to round on the patients at least once a month, but as often as every week. And there's always a nurse in the dialysis center who examines the patient. Okay, so people who do dialysis 3 times a week are those who tend to have swelling, linger, distension of the belly, yes. But please ask him whether he's discussed his symptoms with his doctor.
Okay, good, thank you.
Daryl Armstead.
Hi, doctor. I have a few questions. Why do kidney patients so often seem to develop mobility problems, including neuropathies in the feet, balance problems, and weakened legs?
Yes, so remember I said that removing waste is just one of the many things the kidneys do. The other things that the kidneys do are the kidneys make hormones. Okay, there are 2 important hormones the kidneys make. One is activating vitamin D. When active vitamin D helps to regulate the parathyroid hormone, which is a hormone or a protein secreted by a gland in the neck next to the thyroid gland. And the job of that hormone is to remodel your bones, to keep your bones strong and healthy. When you have kidney failure, you're not able to activate vitamin D, and the vitamin D does not regulate that gland in the neck. So the gland in the neck, goes, for lack of a better word, goes rogue, and it's very high in the blood. It makes the bones very brittle. And the patients, because of brittle bones, they may even have fractures or feel very weak because of that. Okay. The other side complication of kidney failure is the waste can build up in the blood and damage the nerves, and you have neuropathy like you talked about. So some of them have foot drop, difficulty walking, but most of it comes from abnormal bone and mineral metabolism. So keeping all those hormones in balance, all the chemicals in balance, even the acid in the blood, regulating all that, you don't have that when you have kidney failure. Even with dialysis 3 times a week, it's not adequately controlled. That is why, home dialysis is now being promoted over 3 times a week dialysis. So over time, you see that in people who have been on dialysis for years, they end up being in wheelchair. So when I mean years, it's maybe 20 years. Also, depending on other problems they have, if they have diabetes, they tend to do poorly, when they've been on dialysis for years. So that could be a reason why you see people not being able to walk around and function well. The other hormone also I must bring up is the erythropoietin, which is a hormone that makes red blood cells. The kidneys produce erythropoietin. We call it EPO for short. So they have anemia. Kidney patients tend to have anemia, and we have to give them injections during dialysis. If they're not on dialysis, if they're at home, they get injections also to under their skin to treat the anemia. So with kidney transplant, most of these complications go away. The only complications that really don't go away are the cardiovascular complications. So the blood vessel and heart disease complications don't go away, but almost all the other ones go away.
Okay. And on your heat map, are the red areas where dialysis is indicated?
The red areas are the people who are at high risk for kidney failure. So the dialysis is not yet indicated. Dialysis is indicated when your GFR is less than 15. Okay, so so less than 15, but the other red areas on this, the right column, where you have the protein, is just that they are very high risk. You have to do something. So it's a red flag. You're waving that red flag. You have to take your medications, keep your appointments, do all that. But at the bottom, the horizontal level, less than 15, yes, dialysis, kidney transplant indicated. So GFR less than 15, dialysis indicated.
Okay. And the GFR screening, is that a part of the annual physical?
Yes. Yes, so it's a creatinine. So they do a creatinine test. It's part of the panel that most doctors order, either the comprehensive panel or the basic panel. It's always part of those, what we call them, the chemistries. And you use that number to calculate the GFR. The lab does the calculation for most labs. They'll do the calculation for you. But even if they don't, online, you can, plug it into if you Google GFR calculator, it will come up online, and it's going to ask you questions. What is your age? What is your creatinine? What is your gender, male or female? And it will give you the number. It used to ask, what is your race? But we stopped asking about race because we've found out that it's discriminating against Black people because it tends to give them a higher GFR. And when you have a higher GFR, what happens is the doctor says, oh, you're okay, your GFR is 60, when it's actually 55. You should be doing something, right? They may not refer you for kidney transplant early. They may prescribe medications and dose them incorrectly based on a higher GFR. we all believe that race is a social construct, not a biologic construct. So we shouldn't put it in anything to do with making healthcare decisions. Okay, so we've moved away from that. And so when we're doing the calculation, we should make sure that we're not using any calculation that asks you for your race.
I seem to remember that foamy urine may be an indicator of protein in the urine. Is that right?
Yes. So thank you for bringing that up. So that's a question I tend to ask patients. I say, do you see bubbles or in your urine? Or is it frothy or foamy? Most of them, means some of them would say yes, and it will correlate with a high degree of protein in the urine. Some people say no, and they still have protein in the urine. So people don't pay too much attention to that. And sometimes the cleaning solutions in toilet bowls may actually make it foamy. So it's one way to, to detect or to find out if somebody has protein in the urine, but the best way is to measure it.
Vivian Blake, you're on mute.
Oh, she's on.
You're on mute.
Yes, I had a transplant. It was 3 years in December, and I know she was talking about the percentage of how the kidneys are working. Once you have a transplant, and I know that what percentage should it be?
Well, you would hope. I'm sorry. Yeah, you would hope that when you get a kidney transplant, that the percentage should be back to 100%. That is our goal. So if it's a good kidney, and the function should be at the minimum more than 60%, but you'd expect it to be a normally functioning kidney. Yes.
One more question. Okay, now I have a lot of questions. But when you go to the doctor and they go through your blood work with you, and they say, okay, it's 1.4. They give you that number, 1.4.
Yes.
And they drink into the water. And they were saying, you have to drink a certain amount of water, like the transplant, less water. No, the kidney, less water. Transplant, more water. And I noticed when I drink more water, I think the numbers are better. So that really make a difference with the water. And what else can you do besides water?
So the 1.4 is most likely the creatinine they're giving you. So we want to make sure when we get that creatinine, we calculate the GFR, because GFR is actually what makes sense to people. 1.4 could be a good number or a bad number, but if I tell you 1.4 means that your kidney function is 30%, you're going to be concerned. Or if I say 1.4 means your kidney function is 80%, you won't be concerned, right? So we need to make sure that when you get that 1.4, you ask that doctor. That is why this health literacy program, I love it, for the Healthy People 2030, that people understand what questions to ask, okay? So drinking water as it pertains to kidney function, there's a type of kidney failure that can be caused by dehydration. So we always tell people, especially if you take medications, drink plenty of water to make sure that you're washing out the waste well, the medications are not concentrating in your kidneys, and also that you're not dehydrated. When people are on dialysis, we restrict the water they drink. Okay, that's the advantage of doing dialysis at home over doing it in center. You have fewer restrictions when you're doing it at home because you're dialyzing more frequently. When doing dialysis only 3 times a week, the 4 days you're not dialyzing, you have to restrict what you drink. Otherwise, you're going to retain all that fluid. And you have to restrict salt, otherwise you're going to retain the salt and fluid and develop fluid overload where you can't breathe, and you may end up in the emergency room on oxygen and stuff like that. So that's the difference between transplant and dialysis. We tend to restrict water there because they already have kidney failure and the water can be harmful to them. The other question about what else can you do to help your kidneys is treat whatever is causing the kidney problem. If it's high blood pressure, make sure the blood pressure is controlled to a goal set by you and your doctor. If it's diabetes, treat the diabetes. Avoid taking medications or herbs or supplements without asking first how it affects your kidneys, either asking the pharmacist or your doctor prescribing it. Don't assume that all doctors are aware that you have kidney problems. Some of them, at the time they're writing the prescription, they may not even be thinking of it. They may give you the dose that is the dose for people with normal, healthy kidneys. So it's important to let them know that, you know, you've been diagnosed with kidney disease, so that if they're writing even a good antibiotic for you, they may have to adjust that dose. So, you know, treating the underlying condition causing the kidney problem, making sure the blood pressure is normal, regardless of what caused the kidney failure, and avoiding medications that are harmful to the kidneys are the big ones. And then the general lifestyle changes, being happy, being healthy, you know, eating right and exercising.
Okay, thank you. One thing I'm going to address that you said, because I was concerned, I asked a lot of questions when I go to the doctor. I said, wait a minute. So then I went to Georgetown. They talked to the transplant doctor. I said, I don't want to lose my kidney. They say, but different people have different percentages. It depends on the individual. That I was at my level. Is that such thing? Have you heard that before? That different ones, you know, it depends on the individual what the numbers are going to be. No.
The only time I've had something like that is for people who are older. We can say that an older person is expected to have a decreased GFR, but usually not less than 60, right? I gave examples that if you lose 1% per minute per year, you know, and you're 70 years old, your GFR will still be 70, right? If you start at age 40 to lose 1%, by the time you're 70, your GFR should be 70. By the time you're 80, it should be 60. By the time you're 9, unless you're a 90-year-old, okay? So that is why, you know, that's the only time I would say that this is normal for you. So if I have a 90-year-old with a GFR of 50 and they don't have any protein in the urine, again, it has to be without any protein in the urine or any other signs of kidney damage. Like if I do a scan of their kidneys, I didn't go into the details of the testing we do. We also do a scan of the kidneys to see if you have any tumors or cysts and stuff like that. If somebody doesn't have any of those and they're 90 years old with a kidney function of 50, I would say this is normal for your age. Even though it's less than 60, it's normal for your age. Okay. So I don't know why they would say that.
Okay, so
as a transplant surgeon, I would tell you that it may depend upon whether you have had rejection or chronic rejection, or whether you've had acute kidney injury with acute tubular necrosis. And so there are reasons why the transplant surgeon might say to you that your creatinine at 1.4 is the baseline. And so that's one of the circumstances whereby they may say it's individual based upon what level did your creatinine start at. Some transplant patients start at 0.8. Some start at 1.0. Some start at, as you mentioned, 1.4. So the baseline may have something to do with why the transplant surgeon made that comment. I think Dr. Murray is talking about those people who have not had transplants.
Okay, you're right. He said something about baseline. So
baseline, yes. Yeah, okay.
Thank you.
That makes sense.
Dr. Atto.
Yes, again, thank you. These diseases that are associated with the kidney, kidney failure, chronic kidney disease, is there any mechanism of treating the kidney without dialysis, without transplant? Is there any mechanism of going into the nephrons? And then, like we hear about kidney stones, of treating, you know, rearrange or bringing the nephrons back to normal without going through dialysis and transplant.
Yeah, thank you for that question. So there is something called the Kidney X Project, which is a public-private partnership established by Department of Health and Human Services and some kidney organizations, including the American Society of Nephrology for the doctors. They are looking at stem cell therapy, so regenerative medicine, to use stem cells to go into the kidneys and repair the damaged kidneys. So there's research ongoing in that arena, but it's nowhere near bringing it into clinical trials. So
Okay,
you're
thank
looking
you.
at that. Yes.
Thank
you're
you.
looking
Thank
at
you.
that.
I wanted to ask you this question. Some think it's routine for you to get an annual blood level for creatinine and a urine for protein, but some places they do only the blood for creatinine, but they do not do the urine for protein. If you're in such a situation, what should you do?
So if you are the patient, you need to request the urine for protein. That is why I brought, I decided to show these slides to educate people to understand. And that is also the goal of that health literacy, to know what it is that you should be tested for. So you need that urine albumin to creatinine ratio. So both, and the GFR, so creatinine to calculate the GFR, both. If you want to see how healthy your kidneys are, those are the two tests you need to do. An ultrasound, and so an x-ray of the kidneys called ultrasound can also be done to look at a picture of the kidneys to see if you have two kidneys and if you have cysts or stones in the kidneys. But to see how the kidneys are functioning, you need both tests. And if your doctor is not doing both tests, you need to request it. And if your insurance will pay for it, so there shouldn't be a problem requesting it.
Does everybody who has had the annual physical have a urine protein? Because I think the point she's making is very critical. Because
people with risk factors, yeah. So if you have those risk factors, 60 years or older, diabetes, hypertension, anything we know that predisposes to kidney disease, they need to do both because they want to evaluate whether your kidneys are healthy or not. So you need both tests. Yes.
So if you are over 50 and they're not doing the urine protein.
Yeah, over 60, yes. Oh, yeah, if you're over 60, even without hypertension or diabetes and they're not doing it, you need to request it. Yes.
Dr.
Okay,
Moran,
you also mentioned about ways of delaying and preventing progression of kidney disease. Can you talk a little bit more about that?
Yes. So the medications, so the most important way is blood pressure control to a target of less than 120/80, according to guidelines, okay? Blood pressure control. And then what you use to control the blood pressure it also helps slow it down. So if you use medications called ACE inhibitors or angiotensin receptor blockers, which target the pressure within the kidney and decrease the pressure within the kidney to decrease the protein in the urine, those help slow progression. There are other medications that were discovered for treatment of diabetes that they also showed can decrease protein in the urine. They're called, I'm sure you've seen the commercials on TV, Jardiance, Farxiga, and the other one is, trying to remember the name of it. So Jardiance, Farxiga, and Invokana. So those three drugs, they were developed for treatment of diabetes, but it discovered that it also decreases the protein in the urine. And remember how I showed you that protein in the urine is really a game changer. If you have normal kidney function and a lot of protein in the urine, you're as bad as somebody who has decreased kidney function with no protein in the urine. So that protein in the urine is a risk modifier, so to speak. So those medications for, you have the ACE inhibitors and angiotensin receptor blockers for high blood pressure. You have what they call the SGLT2 inhibitors, Farxiga, Invokana, and Jardiance. You also have Ozempic, Trulicity, other medications used to treat diabetes that can also decrease protein in the urine. And there's another one called firanidone, which can also, has been shown to decrease protein in the urine. And all these medications, they don't only decrease protein in the urine, they also improve cardiovascular health. They help to prevent stroke and heart failure in people. So they're wonder drugs. For people who have cysts in their kidneys, who have been diagnosed with polycystic kidney disease, which is a genetic condition, that medication, there's a medication called tolvaptan that has been shown to slow the growth of the cysts and delay the onset of kidney failure. And then in the research arena, there's a medication that is being investigated that blocks a result of a genetic mutation. So there's the APOL1 genetic mutation that increases the risk of, especially people who are of African descent, increases their risk of kidney failure. There's a pill that is being undergoing clinical trials now that can block the effects of that genetic mutation in the kidneys. So it will decrease protein in the urine and slow progression to kidney failure. So there are many things out there. That is why, this heat map will help you know whether you should be talking to a kidney specialist. Your primary care doctor may not know all this. I'm just be saying, no, we'll keep watching you, Say, no, my color chart says I'm orange or red. I need to go see a kidney doctor. Please refer me. And you can self-refer yourself if your primary care doctor will not.
John Buchanan, you had a question? Great answer. Thank you very much.
Dr. Murray, thank you so much for all this great information. You again predicted my next question. I was asking about we have two kidneys, usually. And are there cases where one works and the other one doesn't? If you have kidney failure, you transplant one kidney and the other one's still there. If you want to donate a kidney, you give up one kidney and the other is working. Those are my questions.
Yeah, so when someone is diagnosed with kidney failure, it means that both kidneys are not working. Because remember, we do a blood test. We draw the blood from the wrist, usually from the hand, and both kidneys are working together to keep the blood the way it is. So if you do a blood test and it says kidney, in the number, the range that is kidney failure, it's both kidneys that have failed. One may be working slightly better than the other, but not enough. Okay. Yes. So, and then if you have healthy kidneys, you can live with one kidney, actually donate one kidney and you can live with one kidney. We know that from, the reason we knew that it's safe to donate a kidney is because people in the military, when they lost one kidney due to injury, due to trauma, they lived normal, healthy lives. Okay. The only thing is that later on in life, your blood pressure may start to increase because of one kidney. They may spill a little bit of protein in the urine, but usually nowhere where it's harmful to you, okay? Especially if somebody has been, rigorously tested and evaluated to make sure they're healthy enough.
Thank you so
much. Dr. Murray, would you tell us, you mentioned earlier in your presentation, a very excellent presentation, by the way.
Thank you.
You mentioned American AKI. Could you tell us a little bit more about AKI?
Okay, so AKI is acute kidney injury. So contrast that with chronic kidney disease. Acute kidney injury is usually reversible. Okay, it's usually a reversible, abrupt loss in kidney function. So it's not a gradual loss in kidney function like you see with chronic progressive kidney disease. Is an abrupt, reversible loss of kidney function. But now we know that it can lead to chronic kidney disease. That is why we need to prevent it. Okay, the best way to prevent kidney failure is actually to avoid anything that can be harmful to the kidneys. So a common cause of acute kidney injury is dehydration that leads to necrosis of the kidneys. So somebody, severe dehydration, diarrhea, if someone who has an illness that causes severe diarrhea, or any other illness where they're vomiting and losing lots of fluids and not able to drink enough and keep down, stay well hydrated, that can lead to acute kidney injury. Low blood pressure, maybe due to infection, severe infection called sepsis, especially infection in the blood. that makes somebody get into the hospital in the intensive care unit that can cause acute kidney injury. Medications, okay, I talked about Motrin, ibuprofen, Aleve. They can all cause acute kidney injury. Obstruction. So if there's obstruction to the flow of urine because of an enlarged prostate in men, where the kidneys, when you do an ultrasound, the kidneys are swollen, that can cause acute kidney injury. And if it's due to prostate enlargement, you can put a catheter into the bladder and relieve that obstruction. Kidney stones, especially if they're on both sides, kidney stones on both sides blocking the flow of urine. Those are common ones. Contrast dye. So when people do CT scans or angiograms of the heart, they use contrast dye that can hurt the kidneys. Certain antibiotics, like gentamicin, vancomycin, there's certain antibiotics that can also hurt the kidneys. But a common theme is it's usually reversible. However, it's not really a benign condition. We need to try to prevent it, because the more severe the acute kidney injury, especially to the point where the person needs dialysis temporarily, it can lead to progressive loss of kidney function, to chronic kidney disease. Yeah.
Okay, do we have any more questions? Sylvia Davis, it's good to have you back again with us. We missed you. And do you have any
Thank you so much.
questions?
I have a question. There's such a push on this protein powder. Has there been any research associated with the extra protein in the urine because of, this protein powder that everybody, is pushing now?
Another very good question. If you don't have kidney disease, taking protein powder, that's okay. Especially, if you're doing it because they're not able to eat naturally, people, need supplements who are malnourished, and they need that. But somebody who has been diagnosed with kidney disease has to be careful with protein powders and any other form of supplements, especially if the kidney disease is associated with lots of protein in the urine, because we don't want to overwork the kidneys. When you have the kidneys that's spilling protein in the urine, eating too much protein can make it worse. We try to control the amount of protein and the source of the protein. So we tend to do more plant-based protein than animal-based protein. And then it's a prescription, actually. We don't want to give them, it's a weight-based prescription. We don't want to give them too much protein.
And also, when I went to take my Medicare wellness exam, they no longer said they require a urine test. But listening to you today, I'm scheduled to take another Medicare wellness exam, which is a free exam, and I will definitely ask for a urine test.
Yes. Okay.
That is my biggest concern, is that for many annual physicals, they don't do the urine protein, which is, and we're talking about people who are seniors.
Yes. Yes.
Okay. Thank you much.
Okay.
Daryl?
Okay. Thanks, Dr. Callender. If you don't mind, I'll have to go now. I have another appointment coming up.
Okay, thank you so much. What a superb presentation, and we're going to have to ask you to come back again.
Sure. No worries.
That's a great
no worries.
job. Thank you so much.
You're welcome.
Thank you.
Okay, thanks. Bye.
Thank
Thank you.
Daryl, we got a kidney surgeon online, so can you ask your question to Dr. Callender?
Yeah, sure. Okay, National Institute of Health saying various lines of evidence suggest Black patients are more salt sensitive than whites, which is due to a tendency to retain sodium in the kidneys. So it seems to me like that suggests that Blacks should maybe adopt a different dietary approach since we retain more salt.
I would totally agree with that. And I've always felt that way. And I think evidence makes it clear that we should take less salt. But it's hard to get people to do it. But it's definitely in their best interest.
But Daryl, question for you. Didn't one of your doctors say that you needed more salt?
Well, there's some people who do need more salt because there's some people who are salt losers. But in general, and that's a general statement, that we are more salt sensitive, but that doesn't mean 100% because there are people who actually need to have more salt.
Yeah, because
None of
I would
those
think,
are patients with hypertension, though. Right.
yeah, because I think you have to look at overall health, because things like BMI, diet, uh, uh, glycogen levels, blood pressure, they all work together. If you can keep your BMI low, you have a much greater chance of keeping your blood pressure low, your glycemic level, if it's in line, then, that promotes the kidney health, which is going to reduce your blood pressure. It all works together.
Yes. Okay.
Yeah,
Well,
all things work together for good.
no, to those who love the Lord, those who are called according to his purpose.
I had just a couple of comments. One, John, right before his last kidney transplant, they had trained us on the home dialysis, and I noticed he had to go into a center where he was doing dialysis every day, and he was getting trained, and they had to train me. His whole countenance, his complexion, everything changed. It was much better. And then I realized you're actually cleaning your system every day like you do regular. So I'm glad they are reemphasizing home dialysis rather than going into that clinic 3 times a week, because that's not really enough. And also she said something about refer yourself. Now, how, because Dr. Callender, I want to talk to you probably after we get through being recorded, or I'll call you personally on the phone because I got an emergency again with my sister-in-law. There's some things that we need to change. But how do you refer yourself?
Oh, you just find a nephrologist. And now the question is, if your doctor, you ask your doctor if he can give you the name of a nephrologist. If he can't give you the name of a nephrologist, you don't have a good doctor and you need another one. But if any of you need the name of a nephrologist, well, you heard one right here. But I can get you in touch with a nephrologist if you need one.
Okay, that's what I want to get in touch with
Of
you.
course, she's one of the best in the field, as you can tell. But you asked another part of that question I wanted to answer, but it slipped me. Oh, okay. Then what I wanted to point out is that home dialysis, there are 2 types of home dialysis. There's the home dialysis that's hemodialysis, and there's home dialysis that's peritoneal dialysis. The peritoneal dialysis is done every day. And so it's just like your kidney works every day. Whereas, as you pointed out, with home hemodialysis, you can do it as often as necessary. And she pointed out that the center hemodialysis is only 3 times a week, whereas our kidneys work 24 hours a day. So that the home peritoneal dialysis that you do daily is probably the closest to normal.
But it's just someone that, unlike me, but I was willing to do it. You just got to be home a certain time of the day, because there's one that has more infection if you do it overnight rather than the one that you do it for 3 or 4 hours during the day. And it has to be consistent every day. And then if you get ready to travel, you can send the water and all the equipment to the place where you're going, and it'll be there so you can continue, whether you're in a hotel or visiting someone's home.
Yeah, well, peritoneal dialysis is going to be free of infection unless you add the infection. So peritoneal dialysis is what you're talking about that is associated with infection, but only when you aren't perfectly clean. If you're ideal, however, if once you get infection with peritoneal dialysis, then you have to go back to the vascular and the blood hemodialysis. But you can, as you pointed out, do home hemodialysis at home and do it many times. But there are many people who only do their peritoneal dialysis at night. So and there's some people who do it only in the day, and some sit up. But I think we've learned that the most efficient dialysis is that which is done at home.
Yeah, I have a friend where the peritoneal dialysis didn't work out for him, and he's back at the center, and he's got all the symptoms like the distended belly, um, and they have to keep they have to keep changing his dialysis order, always adjusting it. But so, are there alternatives? It seems like
Transplant.
three times a week it doesn't appear to be enough. But if the home dialysis doesn't work, can they do more often at the center, like 4 or 5 times a week at a center?
You're more likely to do that at home. But if you can't do it at home, then this is the kind of person who actually needs a transplant.
Yeah, well, he's getting close to a transplant, but is it possible to get it more often than 3 times a week at a dialysis center if home dialysis doesn't work out?
Is it possible? It's unlikely, but you have to talk to the nephrologist and make special arrangements, because right now they are doing patients 3 times a week. But as I think everyone's aware that's not enough to be comparable to what a kidney does 24 hours a day. And so actually he or she needs to talk with his nephrologist and see if he can arrange for dialysis to be more frequent or to be longer. So those are the 2 options: to have it more than 3 times a week, or to have it more than 4 hours.
The other thing, doctor, is the 3 times a week issue is also dependent on insurance too, isn't it?
No, it should have nothing to do with insurance. Insurance covers kidney patients. It's the only area where you have universal health care. So, and if you cover dialysis, you cover dialysis. So the duration of the dialysis should have nothing to do with the Medicare or Medicaid covering dialysis. Any other questions? I thought it was a very excellent presentation. And next week we have Dr. Coleman, who's going to talk to us about the urinary problems that older people are associated with. Today we had about the kidney. Next week she'll be talking to us about the urological problems of seniors. And the week after that, we have a presentation by
Obesian.
Dr. Obesasan on the medical problems of those who are over 50. So if you're younger than 50, you can still listen.